for tuning in today. On behalf of the University of California, San Francisco Alumni Association, the UCSF Department of Psychiatry, the Greater Good Science Center at UC Berkeley, and the MindSight Institute, welcome to the third webcast of our series titled Emotional Well-Being During the COVID-19 Crisis for Healthcare Providers. This week's topic is healing moral distress, moral outrage, and reducing burnout. I will now turn it over to our host, Dr. Alyssa Epple.
Hello, everyone. Welcome. I'm going to start with just a little bit of time anchoring for us. There was a cute article in the New York Times yesterday called "What Day Is It?" Because not only are we communally and globally feeling anxiety together, there's also a societal disorientation where people are actually needing to look up what day it is. So here we are in mid-April 2020. We are in many places at the peak of the pandemic. So while we're still in the thick of it, this is also a time when we can take a step back and look down at what's ahead of us. Try to breathe with more ease and really try to be with what is here now today. So that's what today is about, is allowing us to start to process the intense psychological and social consequences of being a human in this time, and particularly being a healthcare provider. So I'm just so pleased to be here to have a discussion with Roshi, Joan, Halifax today. Now, first, we actually have a special guest. As we have witnessed, New York City in particular, the healthcare providers are part of horrific conditions. There in New York, over 10,000 deaths due to COVID. We've talked about how to support critical workers using psychological first aid strategies. Human support is one of the most important components today for us in regulating ourselves. So we're going to hear about a model program that's being used that you might be able to use at your own hospitals. It is the magical ingredient of being there for each other. In the United States, there are over 9,000 healthcare workers, doctors, nurses, paramedics, etc., who have been infected. In our audience, from all of you, it's been amazing to read your experiences that you've shared. So many shared emotions, experiences, complex moral dilemmas. So common experiences from our audience are anger, fear, and outrage at not having sufficient protection for themselves, and then fearing exposing other patients as well as their families to COVID. So I'm pleased to introduce you now to Dr. Jennifer Dorn. She's an associate professor and assistant dean at Columbia in the School of Nursing. She has a very rich history, and what's most relevant here is that she works with pandemics. She was there for HIV and AIDS, for Ebola. She has worked with frontline nurses with first-person narrative research. So she has found that the emotional legacy of trauma that providers carry on long afterward are persistent if they are not supported. So welcome, Jennifer. Thank you so much for joining us. So tell us about how you started this program that you're going to tell us about called Circle of Care. Okay, I can't hear you, Jennifer. Are you muted?
Oh.
Okay, you're muted again. Go back.
Same time.
Hello.
Hi, can you hear me now?
Yes.
Thank you, Alyssa, and thank you for inviting me to be part of this very auspicious presentation with my dear colleague, Roshi, Joan, Halifax. As you said, when this COVID-19 pandemic broke out, I realized at the School of Nursing at Columbia University that I was one of the few faculty members that as a nurse and a midwife had actually worked clinically around HIV in South Africa and many other African countries with nurses and midwives, and doing oral history gathering with nurses and midwives in Sierra Leone and Liberia in last year, 2019. And what I experienced in both cases was that there was a legacy, a leftover of burnout and trauma that had never been addressed. It was a missed opportunity to do healing for nurses and midwives. When I interviewed nurses and midwives in Western African countries 5 years after Ebola pandemic, they would tell me stories as if they had just happened, as if they were right in their minds. And the tears and the silences and the difficulty to go forward was so evident that when this pandemic broke out, and New York being an epicenter at the moment, I decided that my own practice of having a way of counsel that was developed by Roshi Glassman, and which Roshi Joan will speak more of, I'm sure. My own practice and my own life experience did not want to miss this moment, this precious moment for working with nurses who were in fact giving clinical care, and go through this experience with them. And that's why I proposed and developed what I call circles of care.
Can you tell us about the structure of the group? What happens during the group?
Certainly. So they last about an hour. And there's an agreement that's stated at the beginning what the purpose of the group, which is really a time for create a safe space for everyone in this circle, we're in a Zoom circle, to share what they're experiencing at work, when they go home, what they see, feel, smell, hear, and listen to each other. So it's a circle that's filled with lots of silence. A person raises their hand when they want to be addressed, and they speak from their heart. We all listen with no judgment, no evaluation. We're there to just recognize what that person, that nurse, is experiencing. There's no cross-talking, so it's not like someone will say something, then someone else will say, oh, I experienced that, what did you do? No, this is a time of sitting in silence so that we can try and process on a very deep level what we're going through. And it is built in confidentiality. So we do keep track of like how many people attend a circle, how many students were involved. We now have over 100 nursing students who would have graduated next month going in early to the hospital. This is their first major experience as a nurse. Imagine entering the profession as this. So any other countries they do.
Jennifer, tell us what happens when we share silence together like that. What happens in the body and the mind? What happens collectively?
Well, I think what happens, I'm going to tell you a couple of things, comments that people have made, because this will, I think, will grasp it. Their words will grasp it better than I could possibly say it. And you need to understand, in these circles, many of the nurses have been infected, and they've seen their colleagues die. They've seen nurses, doctors, techs die, and there's some of them are in self-quarantine at home while they're recovering. So it's not something that's happening to others, and they know they're at high risk. So a few comments. One nurse said, I struggle when there are many people who have died and they're still in their beds, because there's a long line for someone to come and transport the bodies to the morgue. We have to walk around the beds and the people. This feels so strange. Another said, I'm afraid to open the doors to the rooms of people infected with COVID because they might have died since the last time I opened that door. In the 4 shifts I've done, this is a nursing student who just went in last week, I have seen at least 10 people die. I never imagined this. There's the issue of redeployment, everyone being assigned to a different unit. One nurse said, I'm a postpartum nurse. I spend my life taking care of babies and mothers. I'm now in an ICU. My first day there, I was so disoriented. I was taking care of a woman who was dying and trying to be there for her, and also hoping she would not die on my shift, as I do not know how to do post-mortem care. for her body. I felt so guilty afterwards. And the common theme has been, people have to die alone. This is not what I do as a compassionate nurse. I cannot connect them to their families. There's so much demand, I cannot be with them. In reflection on the circle, people have said, this circle is the first time I have let my feelings out. I'm so busy getting ready for the next shift or there that I never get to feel. Others have said, I'm able to contribute. I'm so grateful for the camaraderie and teamwork of how we all work together. Doctors, nurses, techs. Everyone is tired and stressed and scared and overwhelmed, but we are in it together. And another statement, at first there were only sounds of crisis, the ambulance sirens, calls for codes, the pleas over the microphone for an anesthesiologist to help with an intubation. Now the hospital has added a chime when anyone is discharged home, a chime of victory. Behind our masks, I know we are all smiling.
Thank you, Jennifer. I'm sure I'm sharing this experience of empathic distress with everyone listening. So you've said two things I want to mention as we close. First of all, we will share links to Jennifer's program and write-ups about it. And even low resource hospitals could do this with a peer leading it. You said this is not a nice addition. This is not optional. This is critical care right now. You also said no one will ever be the same. And while we all understand the, scar of trauma, I'd love you to talk about what you've seen on more of the positive or growth side from that. We will never be the same.
Thank you, Lisa. When I said this is a missed opportunity, is that by processing, by having time to get to the feeling level, it's not a nice addition, it's critical for people to go forward. And when people do it, the claim of fullness, the claim of understanding true suffering, and also being able to go on as a compassionate nurse is so much stronger. Without it, I've seen and I've heard stories of many nurses never going back in other pandemics. So the potential for deep growth and better care is right within our hands, and it should be addressed now.
Thank you so much for your amazing work.
Thank you.
We have a lot to learn from you.
Thank you.
All right. Be well. You and Bernie Glassman will stay with us through this session. Okay, so next we're going to move on, and I'm really excited to tell you a bit more about the background of Roshi Joan Halifax. For those of you who don't know her, she is one of my most inspirational people I've ever met, one of my teachers, one of my friends. She's chosen a path of vast humanitarian relief to others, a lifelong path of training the mind in order to be with suffering close up, to be offering ease and peace to people. The situations of death, dying, suffering, these global crises that we have, these are situations that are terrifying to most of us, that make us want to turn away or run away. She's a magnet for these because she can be there to bring relief, peace, growth. So when I thought about this webinar series, I thought of Roshi Joan Halifax as someone that we all must hear right now. She's an internationally renowned leader in the contemplative world, teaching Dharma as well as what you might think of as engaged Buddhism. Each year she trains and leads medical missions to clinics at high altitude in the Himalayas. Her remarkable life, including childhood, is documented in her new book called Standing on the Edge. It's one of the most powerful books I've ever read, and this is a book for pandemic times. So we'll be referring to parts of the book and also videos that you will have so that you can actually hear what she has to say today, and you can actually experience it afterward with her videos and her book. So Roshi founded the Upaya Zen. She founded the Ojai Institute. She was one of the founders of Mind and Life Institute. She founded the Upaya Zen Center, where it's like a contemplative university. It offers trainings to the public and healthcare professionals. She, okay, so I'm gonna stop now so we have time to hear her. Roshi, Joan, thank you so much for being with us. It's so good to see you.
Listen, I'm so grateful that you invited me, and also I'm grateful that there are others that are part of our community that are tuning in at this time, which is a time that is, we keep using the word unprecedented, and it's historic. And it has, within the context of catastrophe, enormous potential for positive transformation. But that positive transformation requires us to name some things. And as Jennifer shared, I've been in the end-of-life care field since 1970, first at the University of Miami School of Medicine, then the Maryland Psychiatric Research Center. And then I began to develop work, not only in terms of working with dying people, but I recognize that the vulnerability of clinicians is unacknowledged. And that vulnerability affects not only the quality of care, but the quality of life that that clinician will leave after an encounter that involves intense suffering and death. So, you know, on one side of the equation, I'm full of stories, but you are full of your story. And on the other side of the equation, what I've tried to do over the years, since I talk often in medical settings, is to, quotes, quantify, that is, ground the kinds of experiences that clinicians encounter that cause clinician suffering and that affect the quality of care, and also affect the viability of the institutions that are holding the context of care, and certainly affect the patient experience and affect often family caregivers who are supporting the patient. So I don't want to be too listy. And I remember a friend once said to me, you know, Christians love God, but Buddhists love lists. So I hope you will forgive me in some cases for being a kind of list-oriented. And I'm doing that because I am trying to give words to experiences which are inchoate. Some of those terms are familiar to you, and some are new, and some are unfamiliar. But so that's a little preface to the questions that I think Alyssa is going to be posing.
Beautiful, beautiful. I think the, so we'll lay some groundwork. We'll first talk about moral distress, moral outrage, and moral injury. I learned about these constructs from you, from your writing, and now we are all witnessing moral distress. Now, this pandemic is more than a threat to our lives. It is a mental health crisis, and it is a moral crisis. So we really want to think about living with moral distress now and how we can do that well. And I want to just start by, I'll let you talk about that, but first we must hear from all of you out there who have shared some of these experiences of moral distress. So I'm going to just show some quotes and read them. And I would like you, as you listen to them, everyone, to let yourself hear them and feel them in the body, and just be with that experience for that moment. So you're going to be both listening and at the same time directing 30% of your attention to the body, because as you will hear from Roshi, Joan, it is actually an embodied experience that we need to the key to regulation versus distress is actually partly feeling the experience and being aware of that. Okay, moral distress. So do you see my full slides here?
I do, Alyssa.
Thank you. During crises, my father always told me to remember your principles. My principles are in pain. I'm witnessing so much injustice. The guilt and heartbreak of being at home, of not being on the front lines with my colleagues is tangible and palpable. So many comments, so many people, older people, people with health conditions feeling so helpless right now to not help and feeling the guilt of that. I have to choose between my deep sense of duty versus the risk to my own family. I feel torn about my obligations to keep my family safe and my obligations to serve patients and their families. If you can think of 20 ways to word this, we've seen it all. This conflict, people are living with daily, making this choice. And then there is moral outrage, also palpable. Like many, I chose medicine hoping to work toward a more equal system of care. I'm ashamed and I'm outraged as the pandemic lays bare our societal inequities and just how little is left for patients and for us healthcare workers. How can I manage rage at government? There were names here. But that was traumatic to see names. So I'm just saying government. We don't need to put salt in wounds. For not protecting us earlier, for assaulting our safety and dignity during this time of great suffering. My entire experience is of gigantic moral distress, from intubating dying patients to limited resources to anger at the government.
Melissa, thank you for sharing these reflections of strength shared. I'd like to expand a little bit the territory of moral suffering, if that's okay. And I'd like to give some definitions that might give us some nuance in relation to the landscape, the geography of moral suffering. I have this in my book. I say moral suffering is the harm we experience in relation to actions that transgress our tenets of basic human goodness. So that harm is expressed in various ways and is reflected in various ways. And I want to particularly acknowledge here the work of Dr. Cinda Rushton at Johns Hopkins, who's an extraordinary ethicist and nurse who's worked in this field and has had a very big influence on me and also our collaboration, both in my experience of teaching and teaching with Cinda, and also doing consultations at Johns Hopkins, where I have learned a lot about this geography. So we see that moral suffering comes in 4 different forms. The first is what Melissa has just mentioned. It's called moral distress. And this experience of moral distress arises when we are aware of a moral problem and we determine a remedy, but we're unable to act on it because of internal or external constraints. And this is so reflected again. Do we have enough ventilators? Is there enough blood for us to give to patients who are bleeding out? Do we have enough people just to do basic care and so forth? Moral injury is something that is primarily associated with the military, but now is being identified more and more in the context of medicine. So moral injury is a psychological wound resulting from witnessing or participating in a morally transgressive act. It's a toxic, festering mix of dread, of guilt, and shame. And I would suggest that not that clinicians are directly involved on purpose in acts that are transgressive of our moral values, but that the institutions and the conditions under which clinicians are working bring a sense of deep shame and a sense of having violated our moral principles to the foreground of our experience. Moral outrage, and we saw this reflected in the second quotes. Moral outrage is an externalized expression of indignation toward others who've violated social norms. A reaction involving both anger and disgust. Moral outrage at unethical actions can drive us to take action and demand justice and accountability. On the can swamp us. The tone, the context of our internal experience can be of extreme self-righteousness, of casting shame and blame on the institution or on others. So there's an important balance that we're to understand. There's a value in moral outrage on an episodic level, but chronic moral outrage will erode our morale in a significant way and could also actually harm our institutions. And moral apathy, this was a lens that had not really presented itself in the literature until I went to see the film about James Baldwin, I'm Not Your Negro, and he used the term moral apathy. And I suddenly clicked. I realized, yes, living in or behaviors of addiction, putting the head in the sand, being tucked away in the safe niche of privilege. Moral apathy occurs when we simply don't care to know, or when we are in denial about situations that cause harm. So the landscape, if you will, of moral suffering is complex. And I think it is a landscape that is important for us to identify and also to understand where we live on that landscape and what are the remedies for transforming moral distress into a relationship that involves not only justice, which is really important, but also profound care. So
Thank you.
yeah, I wanted to name that at the onset, because I think giving these categories, moral suffering being the overarching issue, but under the tree of moral suffering, we have moral distress, moral injury, moral outrage, and moral apathy.
And you've also identified moral residue as what we're left with. And so that brings us to this relationship between these painful experiences and burnout.
Yeah.
And so we know that moral distress and injury predict burnout. And we also know that the ability to hold compassion in these moments, in these experiences, is almost a moderator or a critical factor that can move us to living in these situations and leading to a more resilient response. So I'm just going to read some quotes that we're from people sharing about their compassion or their feelings of not being able to have compassion, this burnout that's already starting. And then we can talk about compassion and really go into what that is beyond the lay term or the lay meaning. So how I'm having difficulty expressing sympathy when I'm feeling so much despair and distress in my own body, in my own life. I'm a Brazilian doctor. I'm seeing COVID patients every day, and I feel overwhelmed. I cry just thinking about their risks and my risks. It's been difficult to feel my work continues to be meaningful when I feel so removed from patients and their families.
Yeah.
Part of the definition of burnout is that feeling of depersonalization and emotional exhaustion. Those are just words we use when we measure it, but this is it. And it's something you train people in to recognize and to work with their experience, emotions, and thoughts. We will be sharing some videos where you lead people through some practices, but I thought first you could really help us understand what is it to be compassionate in the face of suffering, to be present and compassionate.
So, Alyssa, before we do that, I'd like to say just a little bit more about moral remainder or moral residue, because I think that, again, this is an area that is important to name. And it's important to understand. It's just like I recognized with recently the death of several very close friends of mine that I had unprocessed grief. Now, with this situation, in a certain way, we have global and national unprocessed grief, but also because of the lack of autonomy and the lack of agency that we're experiencing, both as individuals and also as nations, we have unprocessed anger.
Mm-hmm.
And let me just say something about moral residue in this regard, because when we encounter suffering that is extreme, or we're in the midst of a catastrophe, and the external resources are not there to meet that suffering adequately, and the internal resources are not necessarily there to meet that catastrophe, that suffering adequately. Afterwards, we could easily experience what is called moral remainder or moral residue. And also, moral residue arises because often we find ourselves in a moral conflict. It's like Yogi Berra says, you know, when you come to a fork in the road, take it. Well, there are, in this condition, these situations that we're facing now, it is one fork in the road after another, and we're frozen in a certain way internally at each crossroad. So moral residue is the unmet obligations and commitments that occur when we have to make hard choices and prioritize one value over another. In every decision we have to make between two competing obligations or commitments, and even when we make the best decisions, all things considered, there are still obligations and commitments that have been unmet. And there is the guilt or regret that we experience in not meeting all commitments and obligations. So moral residue is the accumulation of unprocessed moral distress and the leftover consequence of moral distress. And I think many of us, not only clinicians, but really many of us in the greater landscape of our country are actually working with issues related to moral residue, sheltering alone or with a few others, when we know that a mile from where we are, there are hungry, homeless people bedded down in a small space, and the inevitability of contagion is present, and so forth. So I think moral residue is something that is a very important thing for us to address, knowing that this will be a consequence. And it is a consequence from this catastrophe that we're in, that we will actually be working with directly and indirectly perhaps for decades to come. So the call is now, how do we actually transform these very difficult and in some ways extremely toxic experiences when we feel our values are being compromised by the conditions that we find ourselves in? When we're unable to actually, because of exhaustion, identify the existential and moral contours of the situations that we're encountering that entail the life-death experience of another. So, as Alyssa suggested, I have been in this end-of-life care field since 1970, trying to really understand how those who are caring for dying people can be resourced, how they can, the inspiration and the aspiration that magnetize people into medicine, into hospice work, into being an ER doc, into being a nurse or social worker. How do we actually sustain and nourish those dimensions which give meaning to our lives and allow us to be resourced? And one of the things that was clear to me, working in a medical center, Dade County, a big hospital center in the early 1970s, is that there was a great challenge to clinician well-being because there was the feeling that the work was overwhelming, as Alyssa has suggested, that there was constant moral distress, and that there was no value placed on being what nurses know so well, but of actualizing compassion. And decades later, I had the opportunity to work intensively in developing a heuristic map of compassion. And that map was to be a kind of a guide for me in working with the question, what is compassion? Is it useful to clinicians? Why is there a compassion deficit in medicine? What are the consequences of there being a deficit of compassion in medicine? And how can we train clinicians better to actualize principled compassion in their care of others? So what I'd like to do is go to the PowerPoint, and maybe Noah, you can help me have that happen.
And I'll just say that this is also revealing bare the change we need in our healthcare training and our healthcare system, because the level of burnout going into this pandemic was already high.
And you know, apropos of your comment as we're getting the PowerPoint up on the screen, Alyssa, is that there's an extraordinary opportunity in the midst of this pandemic to look at the culture of medicine and to work for the transformation of that culture in a way that is going to create a whole different ethos and approach to what it means to care for others. Mm-hmm. So I think the PowerPoint is going up.
Okay.
So Alyssa, what I discovered is that compassion involves 4 different elements. The first is really important for us to understand and to actualize as clinicians. It means that we have the actual capacity to attend, to be present for the experience of others. In this case, for the experience of suffering that others are going through, that our attention is not divided, dispersed, or distracted, that we can allocate our attention completely to the person who is in bed before us, seated before us, standing before us. The second element of compassion that is very important is the actual experience of feeling concern. So one of the pieces that you shared where someone feels completely dissociated from care and concern which is an aspect of burnout. How do we cultivate that quality of prosociality where concern is present? The next aspect of compassion is to sense what will really serve others. This is critical. Our capacity to have a clear ability, or our ability to see clearly the suffering of others, for that to arouse within us concern for others, and then for the kind of groundedness where our attentional capacity is not fragmented, where we can sense into what might serve others, and then potentially to be of service. So our work in healthcare is to alleviate the suffering of others and the pain of others, and to be with the suffering of family caregivers to the extent that we're able. And although it's not necessarily explicitly articulated in the healthcare education world, we also, as providers, need to address the truth of the suffering of other providers. And this is not in a third world country. This is a hospital in Switzerland. And this is probably what many of you are in the midst of today. And we know from psychosocial research how pervasive burnout is: emotional exhaustion, depersonalization, and this experience of a really low sense of accomplishment. And of course, physician burnout is associated with a poor quality of care. And it even is happening in the experience of medical education. So one of the things that I did in my survey of the landscape of clinician suffering was to look at attributes that are considered to be wholesome for clinicians, but that have a shadow side. I call these edge states. And this includes the experience of pathological altruism, which is associated with physical or psychological harm to oneself by placing the needs of others above oneself. But it also can refer to, pathological altruism can relate to how we disempower our patients, or how we can harm our institution, or the institutions or countries that we're serving in. If we just take Haiti as an example. Empathic distress is another edge state, and that's the dysfunction that arises from exposure to the suffering of others and the experience of over-arousal, and basically vicarious trauma from others' suffering. And then moral suffering, as I've described, involving moral distress, moral injury, moral outrage, moral apathy. And then very important, the issue of respect and disrespect. And what happens in many settings where there's both horizontal hostility, that is when there's bullying, disparagement among peers, including in the healthcare team, or vertical violence, where someone who has a higher status, say a physician, is putting down a nurse, or vertical violence can come from the patient to the clinician, where the patient is violent or disrespectful toward the clinician. The fifth state that I've described in detail is burnout and vital exhaustion. And this Lisa referred to earlier, and this comes from cumulative work demands and stress, where toxic workplace, and also loss of meaning, and of course, too much work just undoes the individual. And then structural violence, and this is systemic discrimination. You know, who gets the ventilator? Does the old person? Does the person with a so-called disability? Does a person of color or not? How do we address structural violence and systemic discrimination? within the systems in which we work. And then I began to look at a little more deeply at what clinicians face. And I talk about this in terms of the patient is making demands which are unable to be met, or the institution is making demands of the clinician that can't be met, or there are errors in the communication between clinician and patient, or from the point of view of the clinician, just the feeling of inadequacy, that we cannot meet the needs of this patient or the many patients who are coming through the doors of our ER, or the sense of what we're doing as clinicians, as caregivers, truly not benefiting our patients. And then the perception of suffering, day in, day out. You've seen these extraordinary photographs of doctors and nurses in Italy who have the very tight masks, and they're all bundled up in their bunny suits, the PPE, and they're just like from another planet, and they take all this equipment off, and you see the marks of the masks on their face, but the marks in their eyes. That is what has really moved me as someone who has been meditating with the images of these clinicians who give so much to their patients and at great risk to themselves. So there are many misappraisals of compassion, like suffering is catching, or you can be overwhelmed, or it fatigues you, or makes you sick, or it's loss of boundaries. Often it's conflated with empathy, and there's an important distinction between compassion and empathy. Or you, as a clinician, can be seen as weak or unprofessional, or that compassion might sympathize, for example, prioritize sympathy over justice, or it's a religious idea, or I need to take care of myself first. So one of the things that we have felt is important in teaching clinicians about compassion and the importance of compassion is the distinction between empathy and compassion. And empathy, we understand, is a complex step, or a step in a complex response that we have of resonance or of identification or connection with suffering. And concern arises from empathy that is healthy and regulated. But there's an important distinction between empathy and compassion. We could say empathy is a feeling into, or a vicariously sharing the same feelings with another. But compassion is a feeling for another, and it's not necessarily the same as the sufferer's state. And I really appreciate the work of Nancy Eisenberg and Daniel Batson in beginning to parse out the distinction between compassion and empathy. Compassion or empathic concern, which I equate with compassion, is other-focused. It's a congruent emotion when witnessing another's suffering. And it involves feelings such as sympathy or tenderness, whereas personal distress motivates individuals to help in relieving the suffering of others, but it's more focused on oneself, and it's related much more toward relieving one's own feelings of discomfort. And I found it so interesting, and I think Paul Ekman brought this to my attention around Darwin's perspective, particularly in the latter part of his life, where it was not the Spencer idea of survival of the fittest, but really what ensures our human survival and well-being is to understand that compassion points to survival of the kindest. And there's very interesting research in this area where we see that, for example, compassion primes well-being and resilience by triggering brain reward and pleasure networks. And it's health promoting. It lowers stress hormones. and it affirms our moral principles. And when we restrain our compassion, and this is what happens around moral injury, our sense of our moral identity is negatively affected. And when we see those who are compassionate, there's a kind of moral elevation, and we're inspired, many of us, to do the same. And there can be a kind of contagion, not of a virus, but of compassion, moral reaction of goodness. And all of these features point to how important our relationships are in our experience as caregivers, and basically in our experience as human beings. So I asked myself, can there be compassion without attentional and affective balance, without being grounded and also being pro-social, without an ethical and moral motivation, and without the experience of some degree of embodiment, and then with the intention to actually engage? And I realized that compassion is actually composed of non-compassion elements, and these can all be trained, particularly because what has happened in our society at this time is that compassion has, in a way, been driven out of us. And so I developed a very simple tool called grace that's used in medical settings and in educational settings. And this is something like you put in your back pocket for that time when you are sitting in front of an individual who's suffering, and you need to get grounded, to gather your attention, and then to recall why you're there as a clinician, as a human. And then to attune first to your own somatic experience, to your emotions, to what's happening cognitively. And one does this in an instant. This is not, when we train people, it is a much more, it's a much slower process. But it is something that once you begin to understand how easy it is with a breath just to become grounded, and then to recall your intention. I am here as a clinician to serve this patient. This is why I entered nursing, why I entered medicine. And then being aware of your subjective experience, fear, aversion, care, over-identification, in other words, empathic distress, down-regulating, and then to consider what will really serve here. The C of grace. And then the E of grace is engaging, and then completing that interaction interpersonally or internally with acknowledgement what has transpired, forgiveness of self or other, also expressing gratitude, and so forth. Completing is really important. And just completing this very short presentation on how important it is at this time to revalue and instantiate compassion. I recall the words of His Holiness, the Dalai Lama, who said, compassion is not a luxury. It is a necessity in order for the human species to survive. I would suggest, from the point of view of our climate catastrophe, this is not just about the human species. This is truly about all species. But it's also about our experiences as a caregiver, as we confront the magnitude of suffering that we encounter now, every day. So Noah G., if you would remove the PowerPoint.
so much. Thank you. That was a lot of amazing scholarship and contemplative wisdom in a very short period. So thank you for sharing that. I want to ask one more question and end with a meditation. And so this last question is about the edge state. So you write about these edge states and how when we face these traumas and these crises, like now, we're certainly in a societal edge state. There is this opportunity. We have an opening for tremendous change and growth. And that's where we're at. And so, you know, the last time you and I were together, we saw the full moon, the first one of the year in January, the first one of the decade. And we were filled with both sadness for the wildfires in Australia and hope that this is the year. It's this year or bust in terms of saving our environment enough. And so we didn't talk about the pandemic, but it's all part of the same picture of this critical year and this opening. And now that everything's changed, people are looking toward, how do we go back? What are we going back to? What are we rushing back to? And how can we use this moment to develop that stronger societal fabric that will save all beings?
So I think the beauty, Alyssa, that this year is, at least in our calendar, 2020. It's like a message from the world saying it is time for us to see clearly. And how do we see clearly? And this has to do with how do we take care of the mind so that we can, to the best of our ability, to craft a world going forward that is characterized by compassion, kindness, sanity, and a sense of humility and modesty. And I feel that the call in part is about our development as we sit in the midst of this turmoil, the development of moral character. And the development of moral character means that we need to have moral nerve to stand in the midst of complex conditions. We also need to have moral sensitivity. That is, to actually have the sensitivity to discern the contours of suffering and the way that we can respond to suffering to benefit others. So for some of us, I hope many of us, I feel that practice, contemplative practice, taking the backward step, if only for an exhale, allows us to see more deeply into the truth of suffering and into the path out of suffering. So it seems appropriate, Alyssa, that we end this time together.
Okay. I will come back on after the meditation for a closing statement. What you just said, I'm going to listen to again and again. I think what's ahead of us is economic hardship and sacrifices. And we need the moral compass. We need the solidarity if we're going to actually come out on that edge state as a newer, stronger society. So Roshi Joan has many, I'm going to say just core strength statements to leave us with. And these are to be heard and felt with all of our senses. So I'm going to ask everyone to just sit back and let us feel ease and close our eyes as we listen to you. Thank you.
So as Alyssa has suggested, on this next inhale, I invite us to gather our attention onto this experience of the inhale. What a blessing, we can do this. So many cannot. And on the exhale, drop into the body. And know that it is the strong back, our capacity to uphold ourselves in the midst of conditions, and soft front our capacity to be sensitive to the world, to allow the world to touch us, to allow our patients to touch us. And as I say these few phrases, if appropriate, allow them to settle into your deep awareness. May I offer my care and presence, even though it may be met by gratitude, indifference, anger, or anguish. May I offer my care and presence, even though it may be met by gratitude, indifference, anger, or anguish. May I offer love, knowing ultimately I cannot control the course of life, suffering, or death. May I offer love, knowing I cannot control the course of life, suffering, or death. May I forgive myself for mistakes made and things left undone. May I forgive myself for mistakes made and things left undone. May I see my own limits with compassion, just as I view the suffering of others. May I see my own limits with compassion, just as I view the suffering of others. Let the breath be deep in the body. Touching in to why you entered medicine, nursing. What was this calling? That was about serving others, alleviating suffering, being of benefit, of true benefit to others. And trusting in the strength that I have, that you have, the resources to truly be able to meet that calling. So thank you. Thank you, not only Alyssa, but all those who are listening today. I'm so grateful for what you are doing for others. And I really hope that the transformations that will make your job, your work, your service saner, easier, and kinder happen in the medical institutions in which you serve, but as well in our government today. Thank you.
Roshi, Joan, deepest gratitude. Thank you so much for this time with us and all of your teachings. Thank you everyone for staying with us. You will get an email with resources, including Upaya's website. There is a conference coming up, the Varela Symposium. I participated in this several times when it was called Zen Brain. It was life-changing. I became a more humble but wiser researcher, and now we can all join online. It's by donation.
Or donation only.
Thank you so much. I look forward to being with you all next week. We will hear Dan Siegel talking about being at home, helping support our children survive and thrive. Thanks, everyone. Have a great week.
Thank you, Alyssa.
So much.